Jar Oil. The company have filling stations across the country, and our rates are relatively cheaper than anyone else across the country. Jar Oil is the biggest producer and distributor of cement in the country with the most competitive prices in the market.
Excellent jam, Suway.
Yo, apply. Yo, luta do dede. Luta mo nulo jël moto nga andil ma xaalis. Hello? Ano lay waxal?
Bisul mu fine.
What?
Bisul mu fine.
Oh, yes!
Wave Axina Gambia. Deposit and withdraw money, pay bills and buy mobile credit without fees. Transfer money wherever in the country for only 1% fee. At Wave. Bisul mu fine? Wave. Your money is yours.
It's Coffee Time with Peter Gomez live on West Coast Radio, 92.1 on FM, online www.wcr.gm. I received a text message from Dr. Musa Marena, whose title is so long I won't even attempt it. But he works in the Ministry of Health at the Edward Francis Small Teaching Hospital. And the text he sent simply said, "Good evening, Uncle Peter. It's me, Dr. Marena. Is it possible to host a female orthopedic doctor to talk about RTA trauma and drifting?" So the earliest we could have scheduled an orthopedic doctor to appear on the program was Tuesday, the 29th, today. And here we are this morning with Dr. Mariam Joof. Welcome to Coffee Time.
Thank you. Good morning, listener. I am Dr. Mariam Joof, an orthopedic surgeon who specializes in sport medicine. So I'm currently the head of the Department of Orthopedic, which is based in Nemban under Edward Francis Small Teaching Hospital. I'm also a lecturer at the University of the Gambia and then a trainer in the postgraduate program.
Oh, you do a lot. But let's just focus on what you do at Ndeban for a moment. What do you do at Ndeban?
At Nemban, what I do is a typical day in Nemban start at 8 o'clock when we...
8 o'clock? You're running very late today.
Yes, today.
Because you're starting here.
Yeah.
Today you're starting here.
Yeah, but a typical day starts at 8 o'clock. At 8 o'clock in the morning, what we do is we have our morning meeting. In this morning meeting, we have the doctors who spend the night in the hospital come, and then they prepare their presentation, which means the patient they receive during the night. Not all the patient, but the patient that need admission and need special attention will be discussed. Also, on the presentation, on top of the presentation will be the date, and then the most senior doctor on the group, then followed by the next one onto the lowest. The number of patients received, the number of patients that need admission, number of patients that came because of RTAs, the BID, those people, that were brought to A&E death.
What's BID?
That is brought in death.
Oh, okay.
So the number of BID, number of patients that came because they fall from height, maybe usually the kids or the Masoners that climb and then fall and then had to come to the hospital because of that. So those are basically the statistics that we look at. Then every patient will be presented. So we'll discuss the case. They would have already started their initial management, but during this meeting, we either improve under management, we can also change some of the management, and then we can continue with the management. We also use this opportunity to teach the junior doctors. So usually we finish this after an hour or so, but if it is Monday, usually it's longer than that because we have to do it for Friday, for Saturday, as well as Sunday, which means we finish around 11.
So in doctor's language, management is treatment.
Yes. Management is treatment. Yeah. Management could be wider than treatment. Yeah.
Yeah. Well, just say treatment to me, and I'll understand easy.
Yes. Okay, treatment. So that is why sometimes, when we get out, patients are already like angry because they will be like, I was there since in the morning, and they're still not out. Yeah. But we started work a long time ago. we're on the teaching, we're discussing the patient, and then we feel that is very, very important, because at the end of the day, when we come out, we speak common language and we know what is done for all the patients.
Okay. So when you discuss a patient, I mean, what's the kind of information that is flowing around? Let's say I just came with a broken arm, God forbid, and you're discussing me. What kind of information goes around?
So we want to know your age. We want to know your activity. If it is upper limb, we want to know your which of the hands is more important to you. And then we want to know the situation that surrounds that. Then we also want to know, go into the history, physical examination. Doctors will tell us what they found in the examination. Then we display the x-ray, we discuss. Then they will tell us what they have done for the patient, and then we'll see whether they have done everything they were supposed to do. If they do not do it, we add certain things, and then we discuss whether we agree, and then we also plan the next treatment. Like if the patient needs surgery now, we discuss which modality are we using, which is best for the patient, and what is available for the country, of course.
Okay, so I present with a broken arm. Mm-hmm. Why is it important to know which of the, two I have is more important?
Because one of your hands,
yes.
Today if I ask you, Mr. Peter, which of the hands do you want me to take out if you have to choose one? Which one are you going to choose?
I hope you don't ask me that question, seriously speaking. I would say the right one.
Why the right one?
Because I use the left one to support my my limb leg.
Okay, for you, your left is more important because of your limb leg. For other people, it's because they use the right more than the left one, and then for other people, it's the same. It depends on which one is more useful to you.
I use the right one for all my writing, for eating, which is important.
And it is also for epidemiological purpose, but also the treatment, it determines, which of the hands is more important for the patient.
But as you say, this is activity that goes on.
Yes.
That patients and their relatives and those who accompany them to the hospitals don't know about. And usually, when they just arrive, a doctor pops up, disappears, and doesn't re-emerge for an hour or so. Then it's like, oh, you're not holding, you file with you, sir.
Yeah, they are not even, looking at us, but we are on them. We're discussing about the cases, and that is very, very important.
Yeah,
it is very important.
People don't get to know this.
Yeah, so that is why I say, let me just talk about this, because it's important. More so, like right now we are in Nembant, but our clinic is in Banjul. By the time we finish this, we also have to see patients that are admitted. Then from there, the group that's supposed to go to theater will go to theater. Then the other group will go to Banjul. They arrive in Banjul at 11 a.m. And the patient will be very, very angry because some of them were there since 6 a.m. Yes. And they don't understand that we're not starting our work now. We started since 8 o'clock. They never understand
Your boss will tell you that I'm always calling him about a patient that I have, and coincidentally, it's about RTA. All right, my patient. Okay. All right. People, a lot is said about the accident rate in this country. I suppose it would manifest in the number of patients who come to Ndeban or EFSTH with either broken limbs or bruises and what have you. First and foremost, how serious, are road traffic accident, incidents showing up in our hospitals?
It is very, very serious. I cannot even overemphasize how serious it is in the Gambia. Like every day, on average, we receive 30 patients on a day. And all those patients...
Where? Just at Ndeban alone? Or?
At Ndeban alone. And I mean the new patients, not the patient that we have seen before.
Okay.
Every day we receive more than at least 30 patients. This is the average.
On average,
it could be more or less.
Goodness
30 patients that are new. And all of them are coming because of trauma. And most of those trauma are road traffic accidents. You have other trauma like, an old lady walking, falling down. You have those ones, but most of them, 80% of them are coming because of a road traffic accident. And this is very, very serious. When you look at the statistic, Gambia is like number 8 in the world, which is very serious. And this has to do with a lot of things. Like it is said that trauma is different from high blood pressure. Trauma is different from other medical conditions. When a country develops, for example, you expect diabetes, high blood pressure, infection to decrease. But trauma on the other side, as the country develops, it also goes up. Because more people are going to want to have more, more people are going to want to have more cars, You're going to have more roads, population is going to increase, people are going to build story building, people are going to tile their houses, and all those things are cause of trauma.
Really?
Yeah.
I am going to take out all the tiles at home.
You have to, or at least...
And probably relocate downstairs.
Or at least let them be dry all the time, especially if you have an old lady who is there. Because the moment they fall, they're going to have fractures.
Old lady, you're talking to an old man in front of you, and you're
Yes,
not worried about the old man.
Yeah, because the reason why they get fractures when they fall from their height is because of osteoporosis, which is more common in ladies than men. It can also happen to men, but it's commoner in ladies, especially old ladies who are not doing any activities. So the moment they fall, they're going to have fractures of the hip, or at least fractures of the distal radio around the wrist.
Yeah, please
Yeah.
say wrist. Otherwise, I was going to say whatever that means. Okay, so a patient, has just been knocked down by a motorbike. Motorbikes are, really wreaking havoc all over the place. So the patient arrives at the hospital. What do you do first?
So when a patient comes to the hospital, not by a motorbike or by
a car,
we consider this
a bicycle even.
Yes, bicycle is a risk. So we consider this as a high energy trauma. So therefore, this patient should be taken as somebody who is, very, very sick. So in that case, what we do is we try to our first target is to save the life, then the limb. What it means by saving the life is to make sure that any life-threatening condition that is, present in that patient is treated before you look at the limb. Once you are done with that, then you can treat the limb. Because you don't want to treat a patient, with a limb, and then the patient is not living. So you want to make sure that the patient lives first before you go to the limb.
And how do you do that? Do you start, drawing blood and doing all the usual?
We start looking at your respiration, whether you are respiring normal, whether your breathing is normal, whether your circulation look good. We look for other signs of bleeding inside, bleeding that you cannot see. We make sure that the patient is stable. Then after finishing with the general, conditions of the patient, which are more serious than the limb, then we go to the limb, trying to immobilize the limb, giving painkiller, and it's only after that we go for the x-rays.
Okay. And when you receive on average, 30 cases every day, do you have enough doctors? Do you have enough nurses, to attend to the patients as they arrive? Because sometimes you hear, dem nañ fofu nonu, tok nañ, xaar nañ, nekk nañ fa 2 hours before you attend.
So we don't have, because as I mentioned, this 30 patient is just for the new patients. We have other patients that were there before, and they are coming to the SOPD. They are coming to the theater. They are coming.
SOPD is what?
Oh, my outpatient department, the surgical outpatient department.
Okay, thank
you.
It
means patients that were operated, patients that were seen, they come back for their appointment. So these 30 patients, they are not the only work that we are doing. We have the patient group that is in theater. We have group that is at the outpatient department. Then we have group that is at the A&E. For this 30 patients that we are seeing is only seen by 2 doctors and about 2 nurses, because every morning we have 3 doctors. We have 2 house officers and 1 resident at the A&E. They will be there from 8 o'clock to 4 o'clock when they will hand over to the night doctors.
Okay.
And they are the ones seeing this patient. The rest of the group are not part of it, unless it is very severe, like when we have massive casualty. That is the time we come. So you mentioned about timing. I will use this opportunity to introduce what we have now. Now we are introducing this week what we have what is called the triage, and the triage is going to sort people according to the severity of the condition. You can come like 2 hours ago, and I come now. I've been seen before you because my condition is more severe.
Okay.
And we know that this will create problem. Because of that, when you go to Ndeba now, you see a lot of writing being done about the triage. If somebody is a red patient, it means that this patient have life-threatening condition, and therefore this patient should be seen within 5 minutes. However, if you are okay, you may be seen after 2 hours, and people should be able to understand this.
Okay.
Yeah.
Okay. So there's a triage system, in Deban. Why was it not introduced earlier?
It was before. It was there before. This is what we used to do, but it was not structured. But now we have a good structure. The moment you have a very serious situation, you are given a red card. If you are somehow fine in between, but you have severe pain, you have a yellow card. If you are very fine, then you have green card and you can stay.
Okay, all right. Okay. And what about the bed situation in Deban?
Good. You're getting it right. So the best situation...
You were itching to discuss this, huh?
Of course, because we receive a lot of things,
Yeah.
Because of this. So what happened is Deban, we are developing, we are still young, we are trying to come up, and the population of the Gambia is going up. Road accidents is becoming, more serious, more people are involved. When you look at our bed capacity now, we have 63 beds.
Okay.
But sometimes, like last week, Monday, we had up to 83 patients admitted into the service.
Oh, wow.
This happened because these people have situation that they cannot leave the hospital. It's not safe for them to go home. So therefore, they have to stay in the hospital, which means that these patients are going to be lying down on mats, on mattresses, and some of them even on chair. But we don't have options. These are the only way that we can take care of them. And this is why sometimes people talk about Deban, it's like this, but we're just trying to maximize the number of patients that are there under our care.
Okay. Two in a bed, sometimes they even have to make do with a chair.
Yeah, but it's not very, very common because they have a limb and it's very difficult for two to come together. It's very difficult. What is common is for them to have mattresses on the floor, mats on the floor, and the chair.
And as I said earlier, I have a patient, with Ndeban, and when they had their accident, on the first night, they were brought in. After about an hour, more than an hour,
they were sent home.
No, not sent home. The family was told that they had to go to Banjul, but there was no ambulance at the time.
Yes, because right now we don't have X-ray. Probably it will start. The X-ray is there, but it has some technical issue, so probably it will start this week or next week. But before then, all the patients go to Banjul, and then you can imagine the number of patients that go to Banjul every day, and they have to use the ambulance. So it's very, very difficult situation.
So when you say the ambulance, there's only one?
It's more than one, but most of the time we have, they're going to other places as well. And they bring the material. For example, we don't have the autoclave. The material that we are using to operate are coming from Deban. Even some of the blood tests have to be taken to Banjul. So they have a lot to do.
Okay. All right. So they go, they get X-rayed in Banjul, then they come back.
They come back, which we don't want. Hopefully it will be changed very soon. But for now, this is what we're doing.
Okay. So Ndeban needs a new working X-ray system.
Yes.
Yeah, we're trying to put out what the issues of Ndeban are, and you don't know. There might be a good Samaritan listening to the program.
We'll be happy if
somebody may be listening in the US, somebody might be listening in Germany, and decides, here we are, we have this equipment sitting here unused, and Gambia is in desperate need of X-ray equipment and the supply. How about the lab at Ndeban? It's fully equipped?
Yes, I can say that we have all the equipment it takes to run a lab, but right now it's not running. It's not even 1/4 running because we lack in the reagents because of a lot of control. So most of the samples are sent to Banjul. Yeah.
Okay. All right. Let's talk about. Or let me just at this point remind viewers that and listeners that we are talking to Dr. Mariam Joof, orthopedic surgeon with the Edward Francis Moll Teaching Hospital, currently stationed at Ndeban Hospital. Is it hospital or clinic?
It's a hospital. It's a teaching hospital.
Ndeban is a teaching hospital.
It's a teaching hospital. It's just a section of Edward Francis Moll Teaching Hospital. When you come to our signboard, it's Edward Francis Moll Teaching Hospital.
Oh, okay.
Yeah.
But when we say Ndeban, what do we say? Hospital or clinic?
Hospital.
Ndeban Hospital. Okay.
Yes.
Ndeban Hospital. Bone setting. You did a whole research on bone setting. Why? Why are you interested in bone setting?
Yeah, I am currently under research. I'm yet to publish anything on that, but hopefully I will do that very soon. So bone settings, what it means is as we treating bones in modern way, there are other people. Traditionally, it's been treated in another way. So because we used to see patients coming from the traditional way with some complications, so we decided to look at them. And then now we're gathering a lot of information about them, and very soon it will be published. Also, this research has different phases, 3 phases. One phase in which we're going to take information from the patients. Then in the next phase is to meet the TVS. We'll be meeting them, we'll discuss with them, we'll exchange with them, and there will be a lot of sensitization on traditional bone setting. And then the last phase will be re-evaluation of our intervention, which will take place probably in the next 2 years.
Okay, so so what has your research shown in terms of traditional bone setting techniques and modern, bone setting practice?
We have some of them that come with complication. In fact, most of the patients that we see in our site are the patients that come with complications. But it's very difficult for us to decide, because obviously we'll see patients that get complications. If the patients are okay, most likely they will not come back to us and we will not see them. So this is why to determine which one is better will be better done when we go to the second phase, in which we'll be going into the community and see. Right now, we mainly see those ones that have complications from them.
Okay. Yeah. And what do you think of maybe the old way of doing things, having sticks, to help with straightening the bone and, during the healing process and all of that? Probably patients being treated without anesthesia.
Yeah,
especially
it's
when
very,
it comes
very painful. Yeah. So when they use that stick, they are also trying to use what we call the splint. But the difference between us is we know the anatomy, and then we know when it is too tight. But for them, usually they don't know when it is too tight. And some of these patients, because of cultural belief, they believe that when it is very painful, it means it's working.
Oh,
yeah, and
really?
And then sometimes
very
they
unlike
can,
me.
Yes. So sometimes they can watch the limb until it is dead. They will not complain, because they think that is part of the procedure, and that is not, that it shouldn't be. If it is too painful, especially if it is more painful when you had the fracture than now, it means, if it is more painful now than when you had the fracture, it means there's something wrong, so you need to report. Yeah.
Okay, all right. If you, when you send an invitation out, it's usually the men who come forward. And I ask myself, why don't women like being on television or radio? You go to the university, you find women lecturing in political science and all of that, but you ask them to, analyze for you, political developments. They don't want to do that. It's only the men that come forward. You lecture in the university. How do you find female students?
The female students, they are more intelligent, I think. They're now even more than the males, and they know why they are there. They are very intelligent, and they know why they are there. So now in the medical school, we have more female students compared to the males.
So very soon you will have more female doctors in the Gambia than you have men.
Yeah.
Ah.
Yeah.
Well,
very soon.
Dr. Bite and his species are becoming a threatened species. But generally, what do you feel when people complain that in our public hospitals one doesn't get the care that they need? And especially when it comes to medicines, the availability of medication. I think in one of the headlines today, your boss was out saying, no patient should leave the hospital for lack of basic needs, says Chief Medical Director.
For me, leaving the hospital without medication should not be a problem. The problem should be leaving the hospital without the right diagnosis. That is what is serious.
Oh.
Yes. If you don't, if you know your diagnosis, you can get your medication anywhere, and anybody can give it to you. But if you
why would anybody leave the hospital without a diagnosis?
I'm not saying this, but this can happen. Like if you go to a place where, people that are there are not able to do the diagnosis, of course you'll be going without diagnosis, and that is more serious. But if you come to the public, maybe we'll not be able to give you the medications, but at least you get your right diagnosis, and then you can get your medication from anywhere, and that will be safe.
Oh, not getting the right diagnosis is more likely in a private setting than in a public setting. No, because you have people who say, like for me, I mean, I say, well, mansuma febare, lopitani banjul la njikadem.
Of course.
You know, I have that mindset. But you have others who say...
No, but that is how everybody should be. Because when you come to Lapitani Banjul, for example, you're going to see all the specialties. If I look at you and I see that this is where I can stop, but there are things that I do not understand, I invite the specialist. And they're going to see you. You're going to have the best care, the best diagnosis. And now, if you don't get the medication, you can get it anywhere. It's easy to get the medication. But the problem is the diagnosis. I think the hospital, the teaching hospital, is the best place to be. If I'm to be operated or if I'm sick, I want to be in the teaching hospital so that everybody can exchange idea to give me the best care that is possible in the country.
I think you've just created a problem for EFSTH. Now everybody will be going to EFSTH and
yes.
You're already overwhelmed.
Let them just be patient with us. We'll give them the best care that is available in the country.
Yeah, sometimes it's the family, isn't it? They are just impatient. I mean, the person who is sick,
yes,
he or she is just lying there.
Usually they don't complain. And what happened is, at the beginning, they complain, they cry, but by the time they are going home, they are happy and we are friends. They understand us, and then they are now very happy and we are friends.
We hear that, improvement works are ongoing, especially at EFSTH. Talk us through this. I mean, what are you improving when all the work is completed? What kind of EFSTH will we now have compared to what we have today or in the past?
We will have EFTH where every patient will have a bed, where every patient will get the care they need on the site.
Even 10,000 patients, each will have a bed?
Yes, of course. Of course.
Right. Yes, go ahead.
And then I don't think we'll have 10,000 patients because we'll continue to do the education, and then I hope people will be more careful, and then we can do something on road traffic accidents, and we can have less patients. Yeah.
Okay. Let me start taking questions for you. Good morning, Uncle Peter. Please ask doctor, what is the cost for fractures, and what is the recovery process for a fracture? Since we're talking about RTA trauma.
Yes, the most common cause of fracture in the Gambia is RTA, generally, but when I look at my TVS research, it shows that people that are coming from the villages, fall from height is the commonest. Yeah.
Okay. Good morning, Uncle Peter. Please ask the doctor, in her research, is she involving a TBS in generating data to know why patients mostly go for local treatment? This is by Omar.
This is going to be in the second phase. I said in the second phase, it's going to be visiting the TVS, collaboration, getting to understand them, knowing what they are doing, educating them, and also sensitizing the community. So now the only data that we get from TVS is the one we get from the patient. For example, when the patient comes, we ask what was done for you, what kind of screen was applied for you, what do you believe? Those are the things that we get. But in the second phase, we'll be seeing the TVS, and hopefully we get that information.
Okay, as to why people prefer to go to them.
And that we just believe that it's culture, because we ask the patient, why do you go? Why do you prefer? Most of the patient will tell us that. From my research, most of them, the most important item they mark were it was low cost, that is what they said. Then they also said that it was more accessible. And some of them said our attitude was the reason why they go over there.
Attitude?
But this is what they said. This is just option. Some of them said that.
Okay.
That the attitude of the workers of healthcare were the reasons why they decided to go for the TVS man, because the man will touch you, the man will talk to you, and man play with your psyche.
Okay.
So they prefer going there.
TBS is traditional bone setter or bone setting.
Yeah, bone setter or bone setting. But
yeah.
sometimes we prefer using the setting because we don't want to attack them.
Okay.
That is why my study, which is the BOSAT study, it means no more disability accepted from the traditional bone setting, not the setters, because if you say setters, you're going to attack them. But we say the act of doing it.
Okay.
Yes.
All right. We'll say bone setting. We will never say bone setter again.
Yeah.
All right. Dear Peter, Dr. Joof and her colleagues are doing a great service to the nation. Despite the shortage of critical supplies, they go the extra mile to restore smiles on the faces of patients and families. Sincerely yours, your cousin Hassan. How do you do that? How do you put a smile on the face of a patient?
When a patient come and he or she is not able to walk, and then after 1 month or two he is coming back to the clinic working, is the reason why I did ortho. It's very satisfying. I mean, it's good to see them in that situation.
Doctor, what is your advice for people who go for traditional medicine instead of going to hospitals to treat their fractures?
I say no to it. They should come to us. Yeah, they should come to us because the TVS don't know the danger sign. And then from my research, the first year, when I look at the first data, we had about 8, morbidity and mortality. We have 3 mortality and then 6 morbidity, which means they lose a limb. They had amputation of either the leg or the hand. And these were people, most of them were school kids between 10 to 12. It was only 1 adult who was part of that. So it means also the kids suffer more because the decision is taken on their behalf.
All right.
Yeah.
I think you have an important meeting to take care of, so we'll just allow you now to wrap up. But just, why did you take an interest in orthopedic surgery when you could have, chosen other fields?
That is what I said. The reason, when I went to Dakar to do my residency, actually I got accepted into neurosurgery, but after 1 year, because I was posted to go to ortho, when I saw that they were doing great job and patients were happy, the results after your hard work, it was amazing. So I decided to change. Then I went to the department and I asked what can I do to change from neuro to ortho. I was told if you do 2 options. You either pass all your exams for this year, then you can ask for change, or you wait until next year you apply. I say I can pass all the exam, and that is what I did. That is why I become ortho, and I don't regret it. Next fall I have to be this.
Yeah?
Yeah.
Very good. How many orthos, since I'm using your language now, how many orthos do we have in this country?
In this country now we have, in Edwards Francis Mall, we have 6 ortho.
Ah, okay.
So, but
uh-huh.
we have 2 Cubans, 1 Ethiopian, and then now we have 3 Gambian, that is myself, Dr. Marena, and Dr. Jeta, who just arrived. We also have Dr. Ka, who is in the army.
Oh,
yeah.
Very good.
But we are training. In Nemban, in addition to our job, we are also training other orthopedic surgeons. Young doctors are being trained to become one. So,
very good.
Yeah.
Dr. Joof, thank you for your time this morning. How would you like to, part with the audience? What would you like to say?
What I would like to say is, like, everybody preserve your health when you are on the road. Be careful. Don't say, if you touch me, the health given to you by Allah is better than whatsoever we can give you in the hospital. So preserve your health. Thank you. In the hospital. So preserve your health. Thank you. In the hospital. So preserve your health. Thank you. In the hospital. So preserve your health.
Jar Oil. The company have filling stations across the country, and our rates are relatively cheaper than anyone else across the country. Jar Oil is the biggest producer and distributor of cement in the country with the most competitive prices in the market.
Excellent jam, Suway.
Yo, apply. Yo, luta do dede. Luta munu lo jël moto nga andil ma xaalis. Hello?
Bisul mu fine.
What?
Bisul mu fine.
Oh, yes!
Wave Axina Gambia. Deposit and withdraw money, pay bills, and buy mobile credit without fees. Transfer money wherever in the country for only 1% fee. Ak Wave, bësal mu fine. Wave, your money is yours.